Hello, it's Professor Paul Mary making a quick and dirty, or on the slide says quick and simple, but it's quick and dirty too, orientation to common BP meds. I did this because you're probably seeing a lot of them at clinical, and some of your patients might be taking up to 3 different medications to control their blood pressure, and I wanted you to understand why that might be needed. First, let's talk about the subclasses of blood pressure meds. This is not all inclusive, but I picked the ones that I think you're going to see at the level of fundamentals clinical, which is where you're at now. There are a few others, but these are the ones that I think you're going to see at the patient acuity that you're working with right now. So you're going to see some adrenergic drugs, some angiotensin converting enzyme inhibitors. We call those ACE inhibitors. Angiotensin receptor blockers, which are called ARBs. Some calcium channel blockers, diuretics, and vasodilators. So let's start with the adrenergic drugs. These control blood pressure and heart rate by their effects that they have on the sympathetic nervous system. So if you remember, the sympathetic nervous system is your fight or flight nervous system, that when something frightens you or stresses you, it makes your heart rate go up, your blood pressure go up, and it slows down other functions like your digestion. Also makes your pupils get big so that you can take everything in and handle whatever the stressor is that's in front of you. So think of these drugs as antagonizers of the sympathetic nervous system. They can be alpha or beta blockers. They can also be combined, but I'm trying to keep this at a simple level for you right now. It does get more complex, but we're trying to keep it simple for now. A lot of the alpha blockers are used to treat benign prostatic hypertrophy or hyperplasia. This is something that happens in older gentlemen. The prostate enlarges, and as it gets bigger, it can compress the urethra. And so what they have is their problem as they age is difficulty getting their stream started, their urine stream, and keeping it going with some force. So sometimes they'll have a trickling stream or may have a lot of difficulty just getting it started. We have to be careful because these gentlemen that are taking an alpha blocker and an antihypertensive beta blocker, as they get older, sometimes these things can start to not work well for them, and they may have more like a combined effect and get kind of hypotensive with it. And so we just have to be very careful. It doesn't mean they can't take an alpha and a beta blocker concurrently. We just have to be careful and keep an eye on things. And if we notice that that's not working well anymore, maybe we need to make some changes. Beta blockers often end in alol, so it might be OL-OL, ILOL, or ALOL. The primary adverse effects of these drugs is hypotension and orthostatic hypotension, especially when we first begin them, when we're starting a new med. And then with orthostatic hypotension, that's especially when they are getting up suddenly, getting up out of the chair, getting out of bed in the morning and trying to jump up and head to the bathroom. They need to be careful and just maybe sit on the side of the bed and get their bearings before they stand up and head to the bathroom. And just a little patient teaching goes a long way with this. Your nursing implications, and keep this in mind at clinical. So if you see one of these on your patient's med list, you're going to want to assess blood pressure and heart rate before you administer. And you may be thinking the patient doesn't do that at home. They do, some of them do sometimes, but at home, they're probably well and things are going fine for them. But when they're sick, other factors and medications that we're giving them can make their blood pressures lower than they are at home. And so that's why we check to make sure that their current acute condition is not causing an effect that we need to be aware of before we give the medication. Some examples of the beta blockers, and I'm going to say beta blockers because that's most of the time what you're going to see, are carvedilol, atenolol, labetalol. Labetalol we use in pregnant ladies. That's one of the ways we control blood pressure for them. There's only a couple of meds that we can use for them, and that is one of them. But carvedilol and atenolol are very common meds. You'll see, if you haven't seen them already, you will soon. Let's move on to the ACE inhibitors. These work a little bit differently. So these work on they inhibit the conversion of angiotensin 1 to angiotensin 2. So there's a cascade of events that happen where it's a renin angiotensin aldosterone system in the kidney, and angiotensin 1 converts to 2, and that becomes a potent vasoconstrictor. And so these meds interrupt that conversion, or they inhibit that, so you don't have that potent vasoconstriction effect. These usually end in the suffix pril. Okay. The thing to know about these is that you should not give these to women of childbearing age or pregnant women, anybody that could become pregnant. Okay. They are contraindicated in pregnancy and in lactation. And so you will not see this be if you had like a 22-year-old female that needed antihypertensive treatment. We probably aren't going to start her on a pril because of the consideration that she could become pregnant soon. And then you have to go off the med and get her on something else. And so it's best just not to start those in the first place. All right, these are often prescribed after an acute MI because they are protective of the heart after an MI. And these are also preferred. They might be the choice drug for patients who are having hypertension that also have heart failure or diabetes. And so some decisions come into play when physicians prescribe these meds, and they might think about what the patient is experiencing, and sometimes you can choose one or the other that might have better effects for that individual. And so this is one that might work better for hypertension and concurrent heart failure or diabetes. Excuse me. These are not preferred in patients that run a higher potassium level because they can cause a high potassium level. Most of the time they're well tolerated, but different things affect different people differently. And that is something that you might see. So some adverse effects, I've got hyperkalemia on there. That's your high potassium. They can cause a little protein in the urine. And a couple of quirky things about the ACE inhibitors is one of the things you'll see is angioedema. And this can happen out of the blue, even after years of taking an ACE inhibitor. It happened to my ex-father-in-law. He presented with a swollen tongue. And so he had to go off. It was lisinopril that was the med. And this is kind of a common thing with lisinopril. But of course, he had to be admitted, and that did not make him very happy. But they had to stop his blood pressure med, and then we had to start him on something else. So you have to change them over and then get them stabilized on a new med just for whatever reason. And it can happen out of the blue. It can happen like that. And with the mouth, the concern is that if it's in the tongue, it could go on down the throat and cause breathing issues. And so that is considered an emergency, even if it hasn't extended yet to the throat. But you'll see these patients admitted and probably kept overnight, at least for observation, to make sure that edema doesn't increase or spread. And then another annoying side effect of the ACE inhibitors is a cough. This can get better if they're on it for some time, but when you first initiate it, they can just complain of an annoying dry cough. Nothing's coming up. It's just annoying tickle in their throat. So it's just something that's been noticed. Some things to know about ACE inhibitors also is if you are the dialysis nurse, you're going to ask that the bedside nurse hold these meds until after you have dialyzed the patient, because these can be dialyzed out, and then it's as if you didn't give anything at all. So they're not going to have a good blood pressure control. So even if that med's ordered at 9 a.m. and they have dialysis at 9 a.m., you're just going to hold it, put a little note in the chart that says you held it until after dialysis, and then give it when dialysis is complete. And that is acceptable and actually the preferred nursing judgment for that. Okay. Some other nursing implications: always check that blood pressure before you give it, monitor that potassium level, monitor for protein in the urine. And maybe that's not something that you're going to do every shift, but if you have a urinalysis on file, just check it and see if there's any protein present in the urine. And then some common examples of ACE inhibitors are enalapril, lisinopril, captopril, and there are probably others, but I came up with the most common ones off the top of my head that I have seen in clinical settings. The next subclass is the ARBs. These also work against angiotensin, but they block the receptor sites. Instead, it doesn't have anything to do with the conversion of 1 to 2, but it competes for binding sites for angiotensin. And so that's another way to inhibit that vasoconstriction that comes with angiotensin, is to just block the receptor site. So these usually end in the suffix artan. They are often used when the patients don't tolerate an ACE, or in like my ex-father-in-law's case, when he presented with the swollen tongue, we switched him to an artan, and that they just don't have that tendency to cause angioedema or cough the way the ACE inhibitors do. But they share in common that you shouldn't give these in pregnancy, lactation, or in women who can become pregnant. They are also best to administer after dialysis. Always check your blood pressure before you give these. And an example is losartan, but there's lots of them, but that's a very common med that you've probably given. Okay, another subclass is the calcium channel blockers. These don't have a fancy suffix or prefix to help you remember them. They're kind of just out there on their own. They are also considered antidysrhythmic drugs. So some of them are used. These are good choices if your patient has hypertension and some type of dysrhythmia, because you can kind of control both at the same time. So that might be a reason why this might be selected for your patient versus another type of blood pressure med. But this one interrupts or slows the calcium channel, and thereby relaxes the vessels' smooth muscle. You have smooth muscle that lines your vessels and makes them contract and relax, and that's what controls your blood pressure. And so this helps by interrupting that calcium channel. And you'll see that I have in parentheses, these are also used to treat preterm labor. So you're going to learn all about that in RNRS 118 next semester. Your nursing implications are assess blood pressure, heart rate, and cardiac rhythm before you administer these. And I say cardiac rhythm because they are antidysrhythmics. So you want to make sure that your patient's cardiac rhythm is baseline. That might not necessarily be completely normal, but it might be their normal. And when you assess that apical pulse, if that heart rate is less than 60, you would want to hold this med. You're not going to get in trouble for that. You're going to get in trouble if you don't hold it, if there's a need to hold it. So you would just document that you didn't give the med and put a little note in why you held it. A couple of common examples are nifedipine. That's the one that we use for preterm labor. It's also called Procardia. That's the trade name for that. And then diltiazem is another one that's used for blood pressure and rhythm disturbances. And that's the trade name of that is Cardizem. All right. Many of our hypertensive patients will be prescribed a diuretic because in our minds, we think that maybe part of the reason why they have extra high blood pressure is because they have a little bit too much fluid volume. And so a diuretic can help remove some of that extra fluid volume that is circulating in the patient's blood vessels. There are several subclasses. They can lower sodium and potassium levels, so that's something to keep an eye on if your patient's taking any of these. And there is one class of them that can raise the potassium levels, and I'm going to break them down for you. The 3 subclasses that we're going to go over, there are other ones, but at this level where you're at now, you're going to see loop diuretics, potassium sparing diuretics, and thiazide diuretics. So let's start with the loop diuretics. You've probably heard of Lasix. Lasix is the most common loop diuretic. They work in the loop of Henle in the nephron. So when you remember back from anatomy and physiology and you had a picture of a nephron and there's the loop of Henle, that's where these meds work. So they produce a significant diuresis. Usually these work very well and will cause the patient to produce quite a lot of urine pretty quickly. These are used for patients with heart failure, also to control blood pressure and to reduce edema, just peripheral edema. So when you're thinking about how to evaluate if this med is working, you not only would want to look at the blood pressure, but you would want to look at their edema. Does it look better than it did yesterday or better than it did earlier today? And also it has some effects on the potassium level. So adverse effects are also things that you need to consider when you're out evaluating your meds. So that hypokalemia, it can throw off some lab results like uric acid, glucose, and potassium. So just something that might explain why you get a wonky result on something. It might point to your loop diuretic. So nursing implications, check that potassium level. And it says supplement potassium. 9 times out of 10, if you scroll down the med list, you're going to see potassium on the patient's med list also, if they have Lasix ordered. And that's because it is known to waste it. It will waste it. And so you're going to need a supplement to keep that count up. If you don't, they're probably not going to be able to consume enough potassium to offset that loss from the furosemide or the Lasix. All right, the next subclass is potassium sparing diuretics. These work by interfering with the sodium-potassium exchange in the distal renal tubules and collecting ducts. So they work in the kidney. They bind with aldosterone and block the resorption of sodium and water, which will make that sodium and water be diuresed out, okay? These do have a weaker diuretic effect than the loop diuretics. So this isn't going to be the person that your terrible heart failure patient is going to be on. This is maybe your swollen legs kind of person, but somebody that has much more advanced heart failure, this is not going to cut it for them. Okay, used to control blood pressure and reduce edema. They are contraindicated in patients with renal insufficiency or renal failure or a high potassium level, because these can drive that potassium level up, as you can see by the adverse effect. So your nursing implications, always check that blood pressure before you give these, but also look at urine output, look at edema, and monitor the potassium levels. And a real common generic name for this subclass is spironolactone. And then the third subclass that we're going to go through is the thiazide diuretics, and they end in thiazide. So that makes it really, really easy to spot. Sometimes you'll see hydrochlorothiazide abbreviated HCTZ. Of course, only in your notes. That would not be the proper way to prescribe or put an order through in Epic. You would want to select the name of the drug, but in just casual conversation or taking notes, you can abbreviate this HCTZ. These inhibit the resorption of sodium, potassium, and chloride, and it results in an osmotic water loss. These are also not the best choice for your patient who has advanced heart failure. This is okay for a little bit of edema or a little bit of hypertension, but your patient who has congestive heart failure is probably going to need the furosemide. These also relax peripheral arteries, so it reduces peripheral vascular resistance. These should be avoided in renal failure, and their adverse effects are related to the electrolytes that they impact. So watch out for the sodium, the potassium, and the chloride, but especially the potassium. These can waste those also. Nursing implications are to assess the blood pressure before you give it, but in evaluating the med later, look at urine output, look at edema. you should look at the potassium level too. Even before you give it, if the potassium level is low and you don't have an order for potassium, maybe call and get one of those. As you may or may not know yet, too high or too low potassium can cause cardiac irregularities. And so that's why we harp on that. We don't want that count to get out of the sweet spot. We really want to keep that in the therapeutic range. All right, so we're out of the diuretics. Now we're doing vasodilators. Okay, these act directly on the smooth muscle in the vessels. Okay, and that can be used to rescue a very high blood pressure. You might have a patient whose blood pressure is 210/110. This might be somebody that you might give this to. Sometimes they can be given IV. We don't give these in patients that are currently having a head injury. So when you see acute, that means during the time you're treating that. So a history of a head injury might be okay, but if you have somebody that came in and they have a head injury, this would not be something that you would want to give them. Okay, also cerebral edema. If they're in the midst of having an MI, or in coronary artery disease, which is your clogged coronary arteries. Okay, so we avoid those in those settings. Some adverse effects are hypotension. So if you go in and give something to rescue a very high blood pressure, don't forget to follow up on it. And you hope that it comes down some. It's not going to come down to normal range. You hope that it comes down to a safer level. But you don't want to bottom the patient out either. And then you have to give them pressors to try to bring the pressure back up. So always follow up on the meds after you give them. These can cause tachycardia, flushing, where they might take a kind of a reddish look to their skin, look like they're like somebody who maybe has a fever and they're red kind of looking, and headache. That's what HA means, headache. Assess your blood pressure before and after you administer these. Okay, and your med that you will commonly see given is hydralazine, and that's very often used as a rescue antihypertensive for when your patient has a very high blood pressure reading. I hope this helps. This was not an all-inclusive presentation, but will hopefully help you to understand why your patient might be on 2 or 3 different blood pressure meds, and help explain what you're seeing in clinical. I welcome any questions. If you're not sure about anything or you want more information about something, let me know. Otherwise, I hope this helps.